Thank you very much. So this is a bit of a tongue-in-cheek discussion, and I'm going to reintroduce you to call. And I know it's something that everybody gets a little nervous about, they have angst about, and the title of my talk is a trauma call, you are qualified. So I don't have any conflicts, I have nothing of value from this presentation, and it's mainly an opinion lecture, and I've taken call for 45 years. So I feel pretty qualified to talk about taking call. The hypothesis of this discussion is that just because you are subspecialty trained in an elective orthopedic surgical practice, it does not disqualify you from participating in some form of call responsibility, okay? So that means just because you're a total joint surgeon or just because you're an arthroscopist doesn't mean that you can't help out in call. Maybe that you don't need to work at the level 1 trauma center, but I think that in all of our practice environments, you can participate in some off-hour support for your group. So like all of us, I went and looked in the journal the last 4 or 5 years to see if I could find anything, and there's absolutely nothing published regarding non-trauma specialists managing community-type trauma cases, outcomes, or recommendations for non-trauma specialists participating in trauma call. There's a lot written about logistics and academic and private practice governance recommendations, but there's really nothing on outcomes or how to include metrics to evaluate the performance of non-traumatologist taking call. So I want to convince you that trauma call keeps you connected, that the trauma burden in most trauma systems is very manageable, and at some point the community will need you in cases of a disaster. And then I'd also encourage you to maintain your general core orthopedic skill set because you worked very hard to obtain it. I get it. Some people just hate taking call. I've never really understood it. I think that when you went for your interview for orthopedic surgery, I doubt very seriously that you told the person across the table that you weren't going to take call, you weren't interested in take call, and you didn't think that that was part of being an orthopedic surgeon. I don't think you had probably got your residency if you would have put that out there, but I think call is an intrinsic aspect of orthopedic training and orthopedic patient care. I understand why people don't want to do it. There's liability. It interferes with your family and fitness. Sometimes you have to practice outside your comfort zone. There's patient compliance, and it interferes with the development of your subspecialty career interest. There is some survey, and this was from '09, it was American College survey data of 7,900 surgeons where 40% of them suggested that they had some form of burnout, 30% were depressed, 20% had mental status changes, and 7% even had suicidal thoughts. 75% said that they would want to do surgery again. 50% would not recommend it to their children as a career choice. So the college, they feel the stress. I mean, they feel the stress of taking call. In orthopedic trauma, our data is a little better. It says that 20% of our trauma colleagues change practices within the first 2 years, and it's finances, location, and just not the right fit with practice groups. I think we're better in 2024 than we have been over the past 20 years. We now have shift medicine, we have AM trauma rooms, we can pass cases off to one another. I think that there are more favorable employment models. We have very impressive non-qualified MD associates. We have mid-levels, physician's assistants, and bottom line is that we have better pay, we have better tools, and we have better training. So, as yesterday, the vision of the world looks different to different traumatologists. This might be a fracture in Santa Barbara, this would be a fracture in the Middle East, and all of us have been exposed around the world to some of these tragedies. And one of the things that really irritates me is when people say that trauma is only important when it happens to you. And I think trauma is important every day, all day, and every place around the world. So it can unfortunately happen at any place around the world. We've seen it in Haiti. We've seen it in one of our lovely islands in Hawaii. Some of you, I think, were probably in Boston. Some of you from New York. Even small towns in Maine and Columbine. So the bottom line is that these tragedies can occur anywhere in the world, even in our little town in Reno. They will happen again and again. And someday, these injuries are going to be in your backyard. And I think that if you're a call taker, I think that you're going to be more qualified to dig in and help out. We all have the opportunity to participate, and we all have this core general knowledge. So if you're a total joint surgeon or a spine surgeon, your orthopedic certificate says exactly the same thing mine does. It doesn't say 1984, but it does say orthopedic surgery. It doesn't say that you're a joint surgeon or a total knee surgeon. The core skill set, you've worked very hard to learn it. What is the orthopedic core? It's doing a history and physical. It's developing an orthopedic diagnosis. You're taught basic emergency room skills, and you're taught care of the hospitalized patient. I know sometimes it seems to become distant as the years go on, but this is your core basic knowledge. In your PG1 year, you had 6 months of surgery, 6 months of orthopedic training. In PGY 2 through 5, you had 46 weeks of fractures and trauma. You went to a fracture course. You passed part 1 of the boards, part 2 of the boards. You had letters of recommendation, and you have been certified and most likely recertified. So I have a really hard time when somebody tells me that I don't feel qualified to take care of call cases. So the core set in general, as I mentioned yesterday, I think being able to manage vascular compromise, some of the open fractures, compartment syndromes, dislocations, septic arthritis, and some pelvic fractures. We're certainly not asking you to manage these kinds of injuries, but I think community-type injuries are certainly under the purview of every orthopedic surgeon for the reasons that I mentioned. There's tibial plateau fracture, minimally displaced lateral plateau versus a complicated interarticular bicondylar. The one on the right would be transferred or taken care of by your trauma surgeon, but I think that most orthopedic surgeons, I think, could manage that. Everybody's familiar with damage control, and these are nighttime procedures that can be applied and then passed on to the trauma people in the morning. And the worst case scenario is that you can transfer these patients. And finally, last but not least, being a traumatologist allows you to participate in hospital relations. You participate in meetings and quality assurance. You get to know the operating room. You get to know the C-suite members of the hospital that you work in. So I think being a traumatologist opens up all of those opportunities. So what the hospitals need today is quality assurance programs, and you can participate in these. They need coverage models for identifying opportunities for referral. One of the huge areas that you can help with as a traumatologist is the efficiency in the operating rooms, anesthesia alignment, and then helping like this with outreach and education. So what's the bottom line? I think that each of you are trained, tested, and certified from the greatest institutions in the orthopedic world. I think each of you are more than capable of providing on-call services. You and yours will sustain a mass casualty event, and call takers are going to be better prepared to provide a first response. And finally, most trauma systems provide clinical resources and educational opportunities, so take advantage of them. Thank you very much.